Welcome to This Week in Urology. This week we are covering 10 notable papers spanning 3 major themes: real-world advancements in prostate cancer diagnostics and therapeutics, surgical volume thresholds and reconstructive outcomes in benign urology, and optimized patient pathways in endourology and functional bladder disorders. Let us dive in. We begin with a major real-world study. Analyzing over 127,000 diagnostic biopsies performed in more than 116,000 men between 2015 and 2021, researchers observed a nearly 9% decline in the annual volume of biopsies. More importantly, the proportion of cancer-negative biopsies dropped dramatically from 49% to 29%, while the detection of clinically significant grade group 2 or higher cancers rose from 30% to 53%. Meanwhile, the detection of low-risk grade group 1 disease saw only a minimal decrease from 20% to 18%, and the diagnostic accuracy improved, with biopsy to prostatectomy grade concordance rising from 51% to 60%. This large-scale data demonstrates that implementing magnetic resonance imaging in routine clinical care successfully reduces unnecessary biopsies while improving the detection of significant disease. To navigate this increasingly imaging-centric landscape, urologists can turn to a practical guide. Beyond the familiar PI-RADS for diagnosis and PI-QAL for image quality, the authors outlined specialized scoring systems designed to standardize clinical decision-making across different disease stages. These include the PRECISE score, which is used for monitoring patients on active surveillance to estimate radiological change over time. For patients who have undergone focal therapy, the authors discuss the PI-FAB score and the transatlantic recommendations for prostate gland evaluation with MRI after focal therapy, which help identify recurrence. For the post-treatment setting, the PIRR score standardizes magnetic resonance imaging interpretation after prostatectomy or radiotherapy to detect local recurrences. The review also highlights the primary score for interpreting prostate-specific membrane antigen positron emission tomography scans, and the PRIMUS score, which enables real-time risk assessment and targeted biopsy guidance using high-resolution micro-ultrasound imaging technology. Looking at advanced disease, another review in European Urology Focus discusses how prostate-specific membrane antigen radioligand therapy is expanding earlier into the prostate cancer treatment continuum. Originally approved for metastatic castration-resistant prostate cancer after chemotherapy based on the landmark VISION trial, newer Phase 3 trials, specifically PSMA4, SPLASH, and ECLIPSE, demonstrate that radioligand therapy significantly delays progression-free survival compared to a change in androgen receptor pathway inhibitor therapy in patients who are chemotherapy naive. This evidence establishes radioligand therapy as an emerging, highly effective option for patients who have progressed on initial hormone therapy but have not yet received taxane chemotherapy. As we extend the survival of prostate cancer patients, managing the long-term side effects of localized treatments becomes paramount. A review in European Urology Focus addresses the significant clinical burden of genitourinary injuries following prostate radiation therapy, including complex fistulas, urethral strictures, and severe bladder fibrosis. While these injuries are challenging to manage and historically required major surgeries such as pelvic organ extirpation or urinary diversion, the authors highlight that novel endoscopic techniques and minimally invasive reconstructive approaches are evolving, offering less morbid treatment paradigms for this complex patient population. Transitioning to benign urologic conditions, a massive database study from Germany. Analyzing over 1 million cases of transurethral resection of the prostate, along with simple prostatectomies, holmium laser enucleations, and thulium laser enucleations, the researchers established clear annual hospital volume thresholds required to optimize patient safety. For transurethral resection of the prostate, hospitals needed an annual volume of 266 cases to reduce postoperative incontinence, and 279 cases to minimize sepsis. For holmium laser enucleation of the prostate, the threshold to reduce incontinence was even higher, at 290 cases annually, with 140 cases needed to minimize sepsis. In contrast, thulium laser enucleation required a lower threshold of 55 cases for incontinence, but a very high threshold of 331 cases to minimize blood transfusions. For simple prostatectomies, The annual hospital volume thresholds were much lower but still significant, requiring 22 cases to reduce incontinence and 26 cases to minimize sepsis. These high thresholds suggest that centralizing complex benign prostatic hyperplasia surgeries to high-volume centers may be necessary to optimize patient safety and outcomes. When surgical complications or bladder outlet obstruction require major reconstructive surgery, the etiology of the stenosis plays a critical role in determining success. A systematic review and meta-analysis in European Urology Focus pooled data from 33 studies involving over 600 patients undergoing reconstructive surgery for posterior urethral stenosis. The authors argue that bladder neck stenosis and vesicourethral anastomotic stenosis must be reported as separate clinical entities due to their distinct etiologies and outcomes. Across both robotic and open approaches, success rates were consistently higher for bladder neck stenosis than for vesicourethral anastomotic stenosis. Specifically, robotic reconstruction achieved a 92% patency rate for bladder neck stenosis, compared to just 75% for vesicourethral anastomotic stenosis. Similarly, open reconstruction yielded a 92% success rate for bladder neck stenosis versus 80% for vesicourethral anastomotic stenosis. These findings underscore the need for standardized, etiology-specific reporting to help reconstructive urologists select the optimal surgical approach and set realistic patient expectations. In the field of sexual medicine, a prospective multi-center study in urology investigated a surgical option for patients with lifelong premature ejaculation who are refractory to medical therapy. 60 men underwent a modified technique of microsurgical denervation of the penis. The procedure resulted in a dramatic, statistically significant increase in the mean intravaginal ejaculatory latency time, which rose from a baseline of 5.4 seconds to 125 seconds at 6 months. While 55% of patients were satisfied with the surgery alone at 6 months, the addition of medical therapy for the remaining dissatisfied patients boosted the overall satisfaction rate within that subgroup to 63%. Importantly, no patients experienced permanent glands anesthesia, paresthesia, or erectile dysfunction, suggesting that modified microsurgical denervation is a safe and viable option for highly selected, treatment-resistant patients. Our final theme focuses on optimizing patient care in endourology, oncology, and functional bladder disorders. In endourology, a 7-year cohort study in the Journal of Endourology evaluated the safety and feasibility of patient-controlled sedation during ureteroscopic lithotripsy for distal urethral stones. Across 429 procedures using patient-controlled intravenous propofol and alfentanil, the absolute stone-free rate was 95%, and 99% of the procedures were successfully completed on an outpatient basis without the direct presence of an anesthesia provider. The major complication rate was exceptionally low at just 1%, and only 1% of procedures had to be aborted. This suggests that patient-controlled sedation is a highly effective, safe, and resource-efficient alternative to general or spinal anesthesia for distal ureteral stones, potentially freeing up valuable operating room and anesthesia resources. In urologic oncology, we often wonder if bladder cancer behaves more aggressively in younger populations. A retrospective matched cohort study in the Journal of Urology compared oncological outcomes of non-muscle invasive bladder cancer in patients aged 45 or younger to an older matched cohort. After matching 124 younger patients with 350 older patients, researchers found no significant differences in cancer-specific mortality, grade progression, or progression to muscle invasion or metastasis. Interestingly, older patients actually experienced a significantly higher risk of recurrence, with a hazard ratio of 1.53. These findings reassure us that non-muscle invasive bladder cancer does not exhibit more aggressive behavior in younger adults and can be managed safely using standard risk stratified protocols, though younger patients may benefit from a slightly lower risk of disease recurrence. Finally, in functional urology, a prospective observational study in the World Journal of Urology investigated the complex relationship between overactive bladder and irritable bowel syndrome. By studying 144 patients across 4 treatment cohorts, the researchers demonstrated that this comorbidity is not a single, uniform entity, but rather a collection of distinct clinical phenotypes. while dual therapy targeting both bladder and bowel symptoms was generally superior to monotherapy. A stratified analysis revealed that the benefit of dual therapy was highly significant only in patients with a diarrhea-predominant subtype of irritable bowel syndrome and not in the constipation-predominant or mixed subtypes. This clinical difference was mirrored by objective baseline uroflowmetry patterns, where diarrhea-predominant patients showed high peak, tower-shaped curves, and constipation-predominant patients exhibited staccato patterns. This study provides a strong rationale for a precision medicine framework, suggesting that we should tailor our management of overactive bladder based on the patient's specific irritable bowel syndrome subtype and baseline psychological factors. If you only have time for one paper this week, make it the nationwide Dutch histopathology study on the real-world impact of magnetic resonance imaging in prostate cancer diagnostics. This study provides powerful, large-scale validation that implementing magnetic resonance imaging into routine clinical pathways successfully reduces unnecessary biopsies and cancer-negative findings, while simultaneously improving the detection of clinically significant disease and biopsy-to-pathology concordance. Here are the key takeaways from this week in urology. First, the real-world adoption of magnetic resonance imaging in prostate cancer diagnostic pathways significantly reduces overall biopsy volumes and cancer-negative biopsies, while increasing the detection of grade group 2 or higher disease. Second, high-volume thresholds exist for benign prostatic hyperplasia surgeries, indicating that centralizing procedures like holmium laser enucleation and transurethral resection of the prostate to high-volume centers may minimize complications like incontinence and sepsis. Third, non-muscle invasive bladder cancer in patients aged 45 or younger does not behave more aggressively than in older patients and actually carries a lower risk of recurrence. Fourth, surgical reconstruction for posterior urethral stenosis yields significantly higher patency rates for bladder neck stenosis than for vesicourethral anastomotic stenosis, highlighting the need for etiology-specific patient counseling. And fifth, patient-controlled sedation is a safe, highly effective, and resource-saving alternative to general anesthesia for distal ureteroscopic lithotripsy. That's your roundup for this week in urology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.